Hey folks, welcome back to the Brown Surgery Podcast. I'm your host, Dr. Kenneth Lynch. Today I'm excited to welcome back Dr. Jennifer Hubbard to the podcast. She recently gave a talk on caustic ingestion at our combined conference, and I thought it would work really well as a podcast. I'm also going to try out this episode as a video podcast because that's what's available these days, so let me know what you think. And without further ado, let's dive into the topic of caustic ingestion. All right, so I'd like to welcome Dr. Jennifer Hubbard back to the podcast today.
Thank you so much for having me back.
Yeah, Jen, so you just did your combined conference that we do on a regular basis, and you did it on caustic ingestion. And so I thought it was a really great topic and one that we don't really talk about too often. So thank you for agreeing to come back on the podcast after your amazing chest tube episode and talk a little bit about caustic ingestion with me. So just diving right into it, when we talk about caustic substances, how are we defining them and what agents are we talking about specifically?
I think the best way to go here is a broad definition because there are a lot of type of agents. Really, a caustic injury is tissue destruction by any chemical action. Some people even consider hot water to be a caustic agent. I would say for types of agents, there are a lot of categories. There's desiccants, which if you ever order products online, you remember those little white and black packets that come with the beads, the silica gel? That's actually a caustic agent, a drying agent. There's vesicants, there's protoplasmic poisons, and the one that comes to mind for me is hydrogen fluoride, because some of these residents may remember taking care of people who come in with these burns from working in their lab. The one most common that we want to focus on, and probably what we see in our work in the critical care units, is acid and bases for types of agents that cause caustic injuries.
Yeah, and I think that's a good jumping point. When we talk about acids and bases, there's some common household cleaners, right, we should be concerned about when we're talking about agents that patients can ingest and cause a caustic injury.
Absolutely. There's cleaners that have acidic products, there's cleaners that have products that are alkalotic, and I would say the most common type of caustic injury is alkalotic agents, and that probably depends on what industry you're working for or area you live in, but probably it's classically alkalotic agents and classically home cleaners. When I think of probably the worst is cleaners that have sodium hydroxide or potassium hydroxide in them, lye, usually something like Drano, which has that's a very alkalogic substance. And then sodium hydrochloride, which is bleach. So those are probably two common products. There's ammonia hydroxide, which is found in a lot of cleaners, window cleaners, and then hydrochloric acid, which you can see in things like pool cleaners.
And now there's a difference when you talk about epidemiology between adults and children.
Yeah, so I really like to separate these two classes when I talk about the epidemiology because I think the major difference is volume and intent. In children, it's usually a small volume of exposure or ingestion, and most of the time it's unintentional. One thing that I found interesting is the CDC in 2012 had a paper where they just took a month of calls and they found that there was 1,000 laundry detergent exposures reported to poison centers. 48 of them were actually the laundry detergent pods, because if you look at these multicolored little pods, they're colorful. They look like candies.
Kids love it. Yeah, they go after it.
But 99% of those calls were unintentional, and usually it's around age 3 for these pod-related injuries where children are sort of exploring and can't tell the difference between candy and pods. And then adults is probably 7 or 8 ED visits for every 100,000 or caustic injury for adults. Very expensive cost to the healthcare system. And these tend to be non-accidental. In fact, a third of them are associated with psychiatric conditions. And they tend to have higher volume ingestion. I think that's important when you're doing your history, because if a child comes in with a high volume ingestion, and maybe they're not old enough to sort of grasp, they're not at that age of 3 and they can't grasp, you really want to make sure that there isn't something non-accidental happening, because the story sort of doesn't match up in that case.
I know you mentioned in your conference too, regionality. Why is regionality important?
Yeah, I think it's really important because depending on the country and what their law for storage of certain chemicals is, in what industries they work for, it can really change the type of ingestion or the product that they're exposing themselves to.
All right, so now that we have an idea of some of the common household cleaners and the agents we should be concerned about and the differences between adults and children, can we talk about the mechanism of injury for these agents?
I think it is interesting because when we usually talk about caustic injury, we talk about pH. We're wondering which substances are on the extreme ends of the pHs. And I always find it fun to Google the pH scale of common things you eat or household cleaners you see. It is funny to look at what's the pH of a banana, what's the pH of eggs, because we actually have a wide range of pHs that we're exposed to in foods that we eat.
The pH of a banana is 4.
The
Oh my
pH of a
God,
banana is
the pH of a
4.
banana.
See, that's a fun fact. I love that. Lemon juices too, imagine.
Yeah.
Well, so really when we think of caustic injuries, we want to think of the extreme of pHs. So less than 3 or greater than 11 can cause caustic injury. And the reason they do that is they either cause coagulation necrosis or liquefactive necrosis, which everybody's panicking, thinking back to step 1 now. But you just have to remember that those acidic products cause this coagulation necrosis, so that coagulum limits the depth of their damage. That's why we think ingestion of alkali agents is so much worse, because it's that liquefactive necrosis. The saponification of the tissue, when it sort of breaks down to the soapy material, just allows this alkalotic agent to penetrate deeper.
Yeah, what's the difference here? I know you mentioned this, the tar, which I hadn't.
Yeah, I didn't know about it before prepping for the talk. But the tar, or titratable acid or alkaline reserve, is basically the concentration required to neutralize the acid or base, how much ion exchange and surrounding tissue is needed to neutralize the agent that you have taken. So you can have an agent that is maybe not the most of extremes of pHs, but has an extreme tar. And then that can be a very caustic agent. And then another thing that we forget about is heat damage from exothermic reactions can also be caustic. I do like to take a moment here and just point out hydrofluoric acid, because that's really one of the common caustic agents we see. Again, that's the patient who came in from the lab and maybe their hand is burnt from exposure to it, but you can ingest this too. That has a little bit of a different mechanism of action because it has electronegative fluoride ions. They can bind calcium and magnesium, and then you get electrolyte problems, and with electrolyte problems can come arrhythmias. So this really can be systemically toxic, and they should be monitored. If they have hydrofluoric acid that has greater than 50% concentration, if they have more than 5% of their total body surface area exposed, or if they did in fact inhale or ingest this rather than just exposure of the hand in the lab, you really should consider putting them in a floor with cardiac monitoring.
Great. So now that we have an overview of that, how would you start the workup of someone you suspected had a caustic ingestion?
With the same answer for any time anyone tells me to go see a patient in an oral scenario, I start with my ABCs.
Awesome.
Because it is true. These patients are at very high risk for not being able to protect their airway. So I do think you start with ABCs. Make sure you're talking to a stabilized patient before you sit down and ask them, so when did you ingest and how much? When I think of their story, something that helps me is when I'm getting the history, I think story, substance, symptoms. I want to know the general background of how they ingested something, what they ingested, when, and symptoms. Are you drooling? Do you have dysphagia? Do you have abdominal pain? And then this really comes into play with children, because you want to make sure that their story aligns, that they were old enough to unscrew a lid to get the laundry pod. If they had a large volume ingestion, it makes sense why they would have a large volume ingestion. And then exam, just a couple things that maybe we tend to forget when looking at patients with caustic injury is their oropharyngeal airway needs to be examined, because if they have findings on the oropharyngeal exam, they tend to have findings on their endoscopy. And then if their eye or skin has any active exposure to caustic substances, because you should irrigate it off with water. And then you want to do your labs, and something I find interesting about the labs is that if you are very acidotic and you had an acidotic agent ingested, maybe you're just absorbing that agent. Whereas if you ingested something alkalotic and your labs show that you were acidotic, it's probably a little more worrisome, because it truly means you have tissue necrosis and a lactic acidosis. So I find it interesting how you can get the same lab value, but again, depending on the story and the caustic substance that you ingest, it could mean a lot more or a lot less to you.
Yeah, I think that's important, because depending on what the substance that was ingested is going to dictate the rapidity of your workup, right? And so when you're going through this and you're looking at ABCs and the history and trying to get labs, How are you working up the potential for imaging or intervention in these patients?
Yeah, I think we should spend a lot of time on imaging. So, first year exam, of course, in the trauma bay, looking at an upright x-ray to check for free air is the right answer. Now, if your patient's airway is secured and you've got all the information you need and you don't have frank free air, the two images that I find very helpful are a CT scan and an endoscopy. And I will explain the importance of combining these with the help of a visual aid, which we can link, is from the esophagus 6th edition. And the reason both of them are useful is they give you very different information, right? If you have a terrible looking endoscopy, you can say, fine, the mucosa is frankly necrotic, but what about the rest of the stomach? Is it actually transmurally necrotic? And the endoscopy doesn't tell you that. And that's when the CAT scan is helpful because it can tell you that. But the CAT scan can only look for transmural necrosis and it can't really grade your mucosal findings like endoscopy, and that's very helpful for your treatment algorithm.
I think that's important too. And you mentioned an upright chest film to look for free air. And I think typically when we think about this, our mind goes right to the stomach and if there was a gastric perforation or something, depending how long the agent was sitting there. But you've got to worry about the esophagus as well. And so I think too, right, you could potentially see maybe some air in the mediastinum on an upright film initially. It's obviously some folks are going to get other types of imaging, specifically a CAT scan. So
yeah, I think it's a really great point. The question is then, who am I doing this on? Who am I getting this CAT scan and endoscopy on? Who am I worried about? And for a general rule of thumb, asymptomatic patients who do not have an ingestion of a highly caustic agent or an unknown caustic agent that they ingested or do not have a large volume ingestion can probably get away without having endoscopy because in general those people have very low grade findings on endoscopy. I think it's very important to realize that endoscopy should be done within 24 to 48 hours after that injury because the tissue tends to get more frail at that 72-hour mark and you have a higher risk of perforation when you do your endoscopy. So it's something where you should get your GI colleagues on board early. But now it begs the question, well, what about the patient who intentionally ingested something? Is he going to tell me everything that he ingested? Is she going to tell me everything ingested or how much? What if they're altered? Then I don't really have information on how caustic their agent was, how much volume. And then patients who are symptomatic should get scoped. But what about if they have oral pharyngeal lesions? Is that a symptom? You know, if that's a sign on my exam, for me, I would say that counts and they should get endoscopy. If they're in respiratory distress, that to me is a symptom. So it's sort of a very broad range to say a symptomatic patient gets an endoscopy, but I think on purpose because all of these would point to me as someone who needs an endoscopy.
So when you talk about endoscopy, is there a grading scale out there that folks are using?
Yes, the Zargar classification, which sounds like a Disney character name, but basically grade 0, 1, and 2 are not concerning. Grade 3 and 4 are concerning. And grade 3A is focal areas of sort of necrosis, black little specks of black. Grade 3B is extensive necrosis, extensive deep gray, brown, black tissue with ulceration. And then grade 4 is perforation. And the reason this is very useful is endoscopies are graded and CAT scans are graded. And when you look at that algorithm that we mentioned before from the esophagus 6th edition, if you have a very low grade endoscopy finding, 0, 1, 2A, and you have a grade 1 CT scan finding, you can observe that patient for a short amount of time, feed them, advance their diet quickly as they tolerate it. When you get in the middle ground of endoscopy grading 2B or 3A, or the middle ground of CAT scan finding, grade 2 or 3 injury, that's the patient you want serial abdominal exams on. You want maybe to look for alternative nutrition because you want to hold off feeding them. They'll need antibiotics, acid suppression. That's your ICU patient. Mm-hmm. It's when you become that endoscopy grade 3B or 4 or CAT scan grade 4 injury, that's when you have to evaluate for surgical intervention.
So you mentioned depending on like the middle grades there, especially those who don't have a frank perforation, why would you send them to a higher acuity unit like a step down or an ICU?
That's a great question. Because even though you're middle grade, you're not high grade. and you're not perf, but middle grade still has a chance to perforate. So you do have to watch them, make sure they aren't getting sicker, see if they're tolerating food. They're there because they're at risk to progress to perforation and the need for surgery. So even though they're not in the high grade category, which has discussion of surgical intervention, they're at risk for it.
When you talk about the presentation of these patients, is there benefit to lavaging, gastric lavage, or charcoal administration for these patients?
For these patients, the chemical reaction happens so fast that by the time they do present to the emergency room, the lavage is not helpful.
Okay.
The same concept sort of goes for the NG tube placement overall, is that if you're worried about this patient and they're going to get a scope, they can have an NG tube put in under direct vision. Putting an NG tube blindly in this injured tissue when you're not going to get any benefit from lavaging is probably not a beneficial procedure. So I would also, in a patient I saw for a caustic injury, hold off an NG tube placement.
Great. So you mentioned like those middle grade patients that you're watching in an ICU, and there's a supportive care, obviously. We're talking about either H2 blockers or PPIs, probably, right? Is there any other medications that have been found to be beneficial in this population?
There has been discussion of steroids, which I know when every surgeon hears that word, they get a little shaky. They originally thought, because you have caustic injection and you worry about stricture, right? That can affect you lifelong, be very symptomatic. So they originally thought, let's give patients steroids and this will decrease their scar formation and decrease their risk of esophageal stricture. However, the data didn't really pan out to say that that was actually quite useful, and obviously with steroids in themselves, you have a risk of perforation. So in general, steroids probably are not indicated. There is a little bit of data saying that if someone was going to get steroids, it would be a short course of steroids, a couple days, for pediatric patients who have a low perforation risk and a higher stricture risk. So probably that grade 2B injury where they're not high in the high grade, high risk area of perforation, but they still have enough of an injury where they have a risk of scar formation in the future. And again, short course. Oh, and another treatment that I think is worth mentioning and we should not forget about is your psychiatric consultation. This is a caustic ingestion that has a high mortality rate, and if a patient is able to survive this, you want them to get help because surviving a second injury like this would be very hard.
And when you talk about additional follow-up for the patient who has a caustic ingestion, what does the follow-up look like for these patients?
Yeah, that is, to me, is why the endoscopy is so helpful. Because the CAT scan can tell you if they have transmedullary necrosis, but the endoscopy in the grading system can tell you not only their diet management, what unit they're being admitted to, but also their follow-up. So if they were a 2B or greater on their endoscopy, they need to be followed for stricture formation. And obviously you want to wait a little while, so when you are scoping them again, they're healing up, and you don't want to perf them when you scope them again, but you don't want to wait too long until their stricture scar is completely formed, which is probably around 8 weeks. So somewhere around 3 weeks after their injury, they should be subject to repeat endoscopy. So I would make sure they have a follow-up appointment with an endoscopist. And then risk of malignancy too. If they have a grade 2B or greater in their endoscopy, they should be followed every 1 to 3 years. This is a later follow-up that probably starts 15 or 20 years after the injury, but then they do have to get repeat endoscopies after that.
To recap for the grading system, we're talking about patients who have a grade 1-2 injury are the ones who could probably move through the system fairly rapidly, advance their diet like you mentioned, and ultimately get out of the hospital. That middle ground is the tough ground, I think. Those patients definitely need observation to see if they progress to perforation, and then obviously the ones who present with frank perforation are going to have an operative intervention from the get-go.
Absolutely, yeah.
Awesome. So just to recap too, I think when you do have this patient present to the ED, the providers that you probably are going to want to get involved in their care are obviously general surgical consult, right? We're probably going to want to call our GI colleagues for a scope. I guess thoracic surgery, is that only based on what you would find in imaging and or the endoscopy if the esophagus is involved?
I think that's a great plan. I think If this is a symptomatic patient and you're worried, get all the teams involved. And then as soon as you do that endoscopy and CAT scan, if you think they're in the high grade group according to that algorithm, I think that's an excellent plan to get your thoracic surgeons involved.
Jenny, I think this has been a great discussion. Again, this is a topic we don't talk about a lot, and so I really appreciate you coming on today to review it with us.
Thank you for having me. I'll see you next time.
Yes, you will. So thanks again to Dr. Jennifer Hubbard for joining us today and speaking about caustic ingestion. We have a lot of great episodes that we'll be putting out over the coming weeks as we dive into our Chief Podcast project. If there are specific topics and or specialties you would like me to dive into in this podcast, my email is in the description below, so just send me a quick note. Have a great week, and I'm looking forward to having you back with us in the next episode of the Brown Surgery Podcast.